Presence here, and more importantly, thank you for your service as outlined by you and by Senator Shahee. Thanks for protecting and serving our nation. Mr. Bartrum, in response, and I want to tell you that how you respond to this question is really important to me. This is not a throwaway question in any way. In response to your pre-hearing questions, you referenced having, quote, an opportunity to revisit the balance of direct care and community care, end quote. In my view, that balance belongs with the veteran. The veteran gets to decide under the eligibility criteria established by Congress in the Mission Act. And it's the VA's responsibility to work continuously to make certain that eligible veterans can freely choose between high-performing VA direct care and high-functioning VA community care. Do you agree? Why or why not? Would you explain your view on this topic?
I fully agree with you. It is the veteran's choice on how we work to balance that care. Right now, the bureaucratic process that has been put in place before this administration takes an enormous amount of time, and it takes a lot of hoops for a veteran to get community care. One of the things that you did is you passed the best medical interest, and we implemented that. And in the policy statement that Secretary Collins put when he implemented it, part of his words were, we don't need a congressional law to tell us to do what's common sense. And what's common sense is that if the doctor and the veteran decide that they need to have a referral to community care, that the referral to community care should occur, and it doesn't take another doctor or another technician or somebody else to review it. It's just like it is in your private sector. When you and your doctor decide you need a referral and you need to go somewhere, then you get the referral and you go. So that has been implemented. Those are the things that I'm talking about on balancing the community care with the direct care. If you think about our healthcare system in the VA, when I worked for the VA years ago, we were essentially a single engine motor. We had one cylinder and it was direct care. We now have community care, referral care, whatever you'd like to refer to it, and we have direct care. And we need to balance those care activities for our veterans based on our veterans. In the VA, there's things that we do that veterans want to keep coming back and using us over and over, especially if they live within the area where they can get to us. If they don't live within that area, they need to be able to use community care without jumping through 1,000 hoops. But if they want to use our prosthetic care, which I would argue is second to none, or some of our primary health mental care, or some of our primary care, and they live in that area, they should be able to do that and have the choice to do that. But if they need to use while they're in that area based on a referral because we don't have the specialty care, they should be able to get the specialty care that they need where they need it. So that's what I say when we need to balance it. It's form and function, sir. It's structure. It's basic, leadership 101. And having been a leader in both the civil service side as an SES and on the military side as a general officer, that's what I intend to do, is to lead the organization to look at the processes and how to better affect the veteran's patient outcome.
When you say balance or rebalance, it's based upon, I'm paraphrasing or telling you what I heard from your answer. It's based upon the best interest of the veteran, not any other criteria.
Yes, sir. It's the best interest of the veteran and what the law allows us to do.
Yeah, there is the law. Thank you. Mr. Bartrum, over the past 5 years, we've seen a major swing in VA workforce from a record hiring in 22 and 23 to a planned decrease of 10,000 employees in 24, and now further reductions in the overall workforce this year. There has not been a VA staffing strategy in recent history that takes a long-term view, despite the necessity of high-performing workforce for the delivery of timely, high-quality care. If confirmed, what data points and trends will you look at to determine the VHA's workforce needs? What are your goals when it comes to the VHA workforce? And how will you work with this committee to develop a coherent and sustainable VHA staffing strategy moving forward and longer term?
And that's a great question, sir, and I really appreciate that. Is on the strategy of the workforce, as you know, VA has about 470,000 employees. And about 350,000 of those are at VA healthcare facilities facing the healthcare, the veterans and providing care at the veterans. And most of those 350,000 were exempt from the hiring freeze that Ranking Member Blumenthal had identified early on in the discussion. But one of the things that I've committed to working with, and I'd love to work with your staff on it once I'm confirmed, or if I'm confirmed, is also with the our HR Assistant Secretary, Mark Engelbaum, on setting up a workforce structure with manning documents so that we understand what positions and what manning documents you should have, and setting up standard staffing models so that we understand how many staff you need for certain types of activities. We don't have good staffing models in the VA. And the way when I've looked at some of the numbers, and I'm only a senior advisor, so I don't dig into all the different things every day at VHA, but when you look at some of the different numbers on their staffing model, it's not a consistent staffing model. You have inconsistent number of staffing in certain areas and not in others, and we need to normalize that across the platform. So I look forward to working with you and the staff and with my other colleagues at VA to set up staffing models to ensure that we're looking at that to make sure that we're getting the throughput on patient output, and we're getting the service that we need. But what I would want to say is that with all the hiring that went on during the Biden administration, there were between 2021 and 2024, there were over 52,000 full-time equivalents. But what happened during that time? The wait times didn't improve. The wait time for primary care rose from 15.7 days to 24.3. The wait time for mental health rose from 14.7 to 20.4. The wait times for for specialty care went from 24 to 38 days. So the measures that I'm going to look at are what is our access and what are the things that we're doing to improve access. And I see my time's up, so I'll end.
I too see that my time is up. Mr. Workman, I'll come back to you at the next opportunity, and I recognize Senator Blumenthal.